All right, everybody, welcome back from lunch. I'm honored to present today some updates in Dercum's disease pain management strategies. So I am Dr. Stephen D'Angelo. I have my PhD in cancer biology. Additionally, I am a Dercum's disease patient treated by our very own Dr. Karen Herbst. So I'm really excited and, again, honored to be here today to share some of what's worked for me, my experience with the disease, and hopefully share some of these findings with you as well. So for disclosures, I have no financial relationships to disclose, but again, because I'm going to be talking about treatment options, I just want to put out there that I am not a physician. This is really a case study of what has worked for me personally. If you would like to try these medications, please talk to your physician. None of this should be considered medical advice in any way. So just a little about me, about my background, why I'm coming here today to talk to you about these treatments. So I got my bachelor's degree in biochemistry in 2017. I then went to the University of Michigan Medical School for my PhD in cancer biology, finished up there last year, and I'm currently a postdoctoral fellow at Northwestern Medicine, where I focus on tumor genomics. So I've been in academic research for about 11 years now, 11 years of wet lab experience. I try to get really deep into any project I work on. 4 publications going so far, about another 5 in production. I've already garnished over 700 citations from these works. So I like to get really deep into medicine that matters and research projects that matter to people, and that's kind of what we've done with this disease. So I'm going to just kind of go through my presentation as a Dercum's disease patient. Dercum's disease is pretty rare to present in men, and this is a large reason of why I struggled for so long to actually get a diagnosis and why these symptoms kept coming up. So my symptoms pretty much started around the age of 20. In college, I was suffering with brain fog, chronic fatigue, weight gain. Nothing was really working for me. I was overcaffeinated at the gym several hours a day, really trying to cut down the weight. Nothing was working. Just undergoing treatment for stress and anxiety. Everyone's saying, okay, you're a college student, you have a poor diet, you're drinking too much. All these things were kind of dismissed and not taken seriously, even though they were really persistent. So I'm going to kind of do this in about 2-year chunks. Around 2017, I noticed my first angiolipomas that became palpable. At this point, I also started to develop chronic back pain, and even with 2-3 hours a day at the gym, I was unable to lose weight. It was starting to become an issue, starting to see my doctors, and they're starting to look at it a little bit seriously, but again, still saying, okay, maybe this is just more of a personal issue. We're not going to really diagnose you with any disease at this point. So I was undergoing a lot of pain management, traditionally just with NSAIDs. I got my first angiolipoma removal in 2017, started physical therapy, started occupational therapy, and just kind of working to manage the back pain, thinking there was just something wrong. And again, at this point, no doctor that I saw was willing to look into any fat disorder diagnosis or treatment or anything along those lines. Fast forwarding again another 2 years to 2019, the disease really developed into a disease of chronic pain. So the angiolipomas that I had removed in 2017 at this point had recurred. I was developing food sensitivities and GI issues. My chronic pain had developed into nerve pain around the areas of the lipomas, again, which can be common in Dercum's disease. And again, despite exercise, despite controlling diet, was still gaining weight, was still unable to lose weight. Treatment here, again, focusing on pain management, symptom management, many hours a week at physical therapy, chiropractic care, doing exercise. Started working on antidepressants, maybe thinking, okay, maybe this is some symptom of depression that's keeping this weight on and is causing this recurrent chronic pain. But again, at this point, even though these symptoms have persisted for 4 years, as a man with this disease, again, when this disease is rare in men, no type of fat disorder was considered. Going into 2021, further recurrence of these angiolipomas. Whatever was cut out in surgery would then come back 6 months to a year later. These were growing faster, causing more pain. Elevated the pain management routine, started muscle relaxers, started having back spasms. The lipomas were pressing on adjacent nerves. Again, a classical presentation of what we now know is Dercum's disease, but at the time, presenting with these symptoms, really physicians were really hesitant to diagnose with anything. Again, keeping up with PT and chiropractic care, keeping up on the antidepressants, trying different ones, trying SNRIs. The SNRIs helped with the nerve pain, but again, no other aspects of the disease. Coming in again now to 2023, further recurrence of the angiolipomas. At this point, I had over 20 of them removed, some of them quite large, up to the size of a fist, other ones as small as a grain of rice. Surgical removal was kind of the standard of care. The surgeons that I talked to said, oh yeah, we have a few people that come by with these. They come by every 6 months to a year, give them surgery, and then they go home. So there seems to be an underdiagnosis of these type of lipoma-forming disease that are just managed surgically without referral to proper care. And at this point, when I was having quite a lot of nerve pain and regionalized pain in the back, one of the things that really helped me, and again, I might recommend just to the patient, was actually trigger point injections, where you look into the muscle knots and inject lidocaine, bupivacaine, other local anesthetics into these regions of local inflammation, and that can kind of bring down inflammation locally. It wasn't until 2024 when I was reading online about trying to figure out what's wrong. And at this point, I'm 4 years into my PhD, and I found articles by Dr. Herbst talking about Dercum's disease that seemed very eerily similar to everything I had. So I reached out to her, set up an appointment, and finally received a Dercum's disease diagnosis, and we began the treatment overhaul that I'll talk to you guys about today. So again, this is about 10 years of symptoms. All of them at any point are pretty general. You wouldn't really see any broad diagnosis from these. Only when you look at them in culmination over the extent of the time that they occurred, you start to see the pattern emerging. So looking at Dercum's disease, it's really hard from a clinical perspective to look at one overall thing and find something that relates all of these different symptoms, these system-wide symptoms, into one thing that causes it all. And I think, like with a lot of areas of biology right now, the issue is you might just be looking at it wrong. So is Dercum's disease causing every single one of these symptoms individually? Well, that's a system-wide approach, but this has also been over 10 years of having this disease and having it go untreated. So do we have to take a step back and look at what is going on besides just this broad diagnosis? So with the insight from Dr. Herbst, we've kind of taken a new approach to looking at the disease, where Dercum's disease is the disease of adipose tissue dysfunction. And a lot of these fat disorders I think we can think of as a disease of adipose tissue dysfunction. But that begins the cyclical process, a self-reinforcing process of these nodule formations or these regions of diet and exercise-resistant fat that start promoting chronic inflammation, can start promoting mast cell activation, and then they all just start reinforcing each other in this never-ending cycle. You address one of the arms, the other ones will flare up and come back. You cannot treat this one thing at a time. You can't just remove the angiolipomas and expect it to go away. You can't just treat the inflammation and expect it to go away. You have to hit the entire thing as a system. So we've come in and separated these into the different issues and come in with different medications to hit each one of these arms individually. So let's just kind of go through kind of one step at a time of what we've done. So addressing regional chronic inflammation, kind of one of the main complaints to the disease. So regional chronic inflammation is more of a system-wide effect instead of a regional localized effect, and we have to really think about it. So as we've heard a lot, you have to go on an anti-inflammatory diet. So when I started doing this, I cut out gluten from my diet for about 1.5 years. It helped my systems massively. Slowly worked it back in. Cut out dairy entirely, reduced red meat, sugary drinks, cut out all processed foods, minimized alcohol. Again, getting that inflammation under control, starting with the diet, starting with the triggers. And then moving on to anti-inflammatory supplements. So one of the primary antioxidant systems in the body is selenium. I've written an article on this. I have several research articles on this on the cancer side. Selenium is an essential toxin, is what we call it. You want to be very, very careful with your selenium intake. You only need about 50 micrograms a day to maintain your proper selenium levels. If you're taking over 400 to 500 micrograms a day, it can become poisonous. So be very, very careful with your selenium intake. But other supplements such as N-acetylcysteine, quercetin, vitamin C, vitamin D, these are all essential parts of your anti-inflammatory system. And if you're dealing with an inflammatory disease, these are supplements to consider working into your treatment plan. One of the things that's worked for me the most for just dealing with the regional pain has been trigger point release. And this has been massage, acupuncture, chiropractic care, doing, again, trigger point injections for quite some time, lidocaine, bupivacaine, directly injecting to those muscle knots and working out those regional parts of inflammation that were outside of the disease but arose from the system tissue. Lidocaine patches help tremendously as well, but again, this is all part of a system. This on its own probably wouldn't have had the effect that it had as part of this large treatment plan. The next one is trying to work on the chronic pain. So the growing angiolipomas for me were constant, sources of pain. They were extremely tender to the touch, radiating pain from the lipomas, and even the ones that weren't painful would spark up chronic pain in the region adjacent to it. I used to start knowing when I had a new angiolipoma growing when I would get a recurrent muscle knot that just wouldn't go away no matter what I did to it. So it was affecting the body outside of the angiolipoma, even if the angiolipoma itself wasn't causing pain yet, but eventually it would grow large enough to the point where it did. So I'd also find that whenever I did a large surgical procedure, those tumors would recur. In about 6 to 8 months after any large operation, I'd start to get recurrence in that site. And because when you're doing a surgery, you're creating a scar, you're creating a new wound, and that is going to recruit inflammation to heal that wound, and then that's going to restart the process. So for me personally, what's worked well has been doing routine small removal, just local anesthetic, working with a good surgeon, and getting them out as soon as they start to grow and that you start to notice them. And that was, again, working for quite some time, and ever since I've actually started this routine, I haven't needed any lipomas removed in about 15 months, where I was getting them removed about every 3 to 4 months before. And then another aspect to consider is when you're looking at chronic pain is a poorly understood disease, but it can lead to this thing called hyperalgesia, which is a chronic sensitivity to pain. So when your nerves are firing and sending pain signals for such a long time, your body expects them all the time. So when you have hyperalgesia, when you're in chronic pain for a period of longer than 6 months, this is something to consider for patients as well, that your pain signals might be misfiring. And so your pain is real. That's always something important to consider. The pain you are feeling is real, but the source of it can be molecularly misleading. So in this case, we did an SNRI and NDRI combination. Again, this is something to be very cautious about and work with a physician on this plan. But the medication duloxetine is very well known to reduce chronic pain and then resensitize those nerves to bring them back to normal, kind of do a reset on the nerve pain. And again, this is something that should be done and closely monitored by a physician. Use NSAIDs sparingly. Overuse of NSAIDs is linked to leaky gut. This, again, can cause more inflammation. So you want to avoid anything that could then reactivate that cycle. So what I do now is I typically either cycle with acetaminophen, so I'm now overusing NSAIDs, where I use a dual pain relief, ibuprofen acetaminophen, that reduces the amount of each that you need to take, and it leads to an overall system benefit. The other thing to do is to avoid opiates. We know that opiates can stimulate mast cells, which again can release more pain signals. So even though the theory is, okay, you're in a lot of pain, you want to take an opiate, that could help with your short-term pain, but then elevate the pain in the long term. Coming in with a lot of other fat disorders we see, there's symptoms and signs of MCS as well. So mast cells are really the activators and the drivers of pain throughout the body. And so it's also known that angiolipomas have high densities of mast cells within them. If you do a biopsy of an angiolipoma, you're going to find a high mast cell population. And the theory that Dr. Herbst had is that when you're looking at angiolipomas, especially ones that have these poorly formed blood vessels within them, and in addition to the increased density of the tissue, these mast cells can become stuck in that fat tissue. Or you can have red blood cells that get stuck in the tissue and die. And now you're clearing out necrotic tissue, again, increasing inflammation. So the one drug that has been the absolute game changer for me has been this molecule called pentoxifillin, which is actually just an adenosine molecule. It's an adenosine mimetic. It works as an anti-inflammatory and also as a vasodilator to clear out those mast cells, to clear out those necrotic cells, and help the body system-wide reduce signs that can help with chronic pain. To reduce MCAS, we do over-the-counter antihistamines twice a day, combination type H1 and H2. So your H1 antihistamines are your typical over-the-counter allergy medications. Your H2 is your typical stomach relievers, your Pepcid, stuff like that. So I do those twice a day, and that's helped immensely with, again, just all my GI issues as well, but also daily pain has come down as a result of those. And lastly, you want to address the source of it. What is causing the disease from the beginning? And that we think is the adipose tissue dysfunction. How do we address this directly? We think adipose tissue, it's overlooked that it is an endocrine organ. It's a major organ of the body. It's not just a fat and energy store. So how do we target adipose tissue metabolism? One of the things recommended by Dr. Herbst was to slowly build up intake of dextroamphetamine sulfate. This is one of the salts in the generic Adderall, but it has a primary effect also on lipid metabolism and alters lipid metabolism. Dextroamphetamine is known to reduce visceral fat deposits. It's known to alter the way that your body uses and stores energy. And it also helps with the systemic brain fog that's associated with this disease. So we build up over about 3 months to the maintenance dose of 20 milligrams a day. I felt very minimal brain effects from this, and this has just been absolutely amazing. I've been able to resume work. I was, considering going on disability for a little bit, having so much trouble with the chronic pain and everything else, and these medications have really put me back to a state where I'm fully functional. The other thing that's immensely helped over the last few months for me has been going on the dual GLP-1 GIP agonist, tirzepatide. The new triple agonist, retatrutide, is still in clinical trials, but I expect this one to work even better. You only need to use about 2.5 to 5 milligrams per week. This is the starting dose of these medications. This is when you see the inflammation markers reduce. You look at all the studies that are currently using tirzepatide, you're seeing people reduce their heart attack markers, their cardiac markers are all going down. Inflammation is going down system-wide as a result of these medications. These things do a lot more than just reducing appetite. They're targeting something in adipose tissue metabolism that we still don't understand, but these are incredible molecules that, again, are currently being studied. And again, going to the diet, focusing on high protein, low to moderate carbohydrates, again, eliminating all processed foods, eating healthy, cooking meals at home, keeping carbohydrate intake low. All of these have helped reduce my symptoms and led me to be able to manage my disease. So going into kind of a summary of this treatment plan, the main medication that worked for me was pentoxifillin. So if there are people that are struggling, I would talk to your doctor, talk to a physician about considering this. Again, I'm not a physician, I cannot give medical advice, but this is what has worked for me. The combination of antihistamines has helped with gut issues. It's helped with MCAS and chronic pain. The SNRI and NDRI combination has helped with my hyperalgesia and chronic sensitivity to pain. I was able to eliminate my trigger point injections once I started on this combination. The dextroamphetamine sulfate, again, helps with your metabolism, helps with the brain fog. Daily multivitamin is essential to get that selenium input, get those vitamin inputs, but again, be very careful to not overdose on your multivitamins. Several of them you do have to be careful about. Anti-inflammatory supplements, I take N-acetylcysteine and vitamin D twice a day. Quercetin is also a great anti-inflammatory. Whichever one works for you, it's your body, you know best. Do whatever works. I currently take Zepbound, just elevated to 5 milligrams after about 3 months on it, once they drop the price. I do this once a week. I've lost about 40 pounds on this. It's just been an incredible medication and also reduced chronic inflammation just system-wide. I try to limit my NSAID usage, but I use it as needed. Again, the key to all of this is moderation. You can do a diet plan, really focus on that anti-inflammatory diet, figure out your triggers, but then live your life. You don't have to do some extensive plan all the time once you have everything under control. But my firm belief is that if you take any one of these and use them as an isolated agent, it wouldn't work. The reason why this plan is working is because we're hitting the entire system. We're hitting it at all the different angles and preventing the body from rebounding and compensating in some way. But again, what we're doing here is we're still treating the symptoms. This has worked for me. I've been on this plan for about 16 months. I've had massively reduced angiolipoma growth rate. I've had several of my angiolipomas actually regress purely from chemical treatment. I've had massive improvement in my blood panel. My triglycerides and A1C were both down. I've had sustained weight loss, currently about 15% body weight reduction, increased energy and focus. I'm working full time, back to an active life, and my brain fog is down to almost nothing again. So this has really managed the disease for me. But so what's next? So this is great for one person, but this is still a case study. You know, science doesn't work from just saying, okay, this worked for me, now everybody go out and try it. Everybody's an individual. This worked for me, this might not work for you. We don't know these. I could be fooled by the placebo effect myself. These are all things to consider. But focusing on reducing the systemic inflammation system-wide appears to treat aspects of the disease. And this is something we need more data on. So the big question is, what causes this disease? We still don't know. There's still no known genetic marker for Dercum's disease, and that's something that we want to look for. We want to look into seeing, can we start clinical trials around this disease? Can we start working with patients to evaluate these markers, evaluate these drugs one at a time, and then bring them into the system to find which ones are needed, which ones are not? I can say right now, as a scientist, I'm probably taking medications I don't need. But for me, with my system, I don't want to stop anything. But what is the minimum that a patient needs to start feeling better? We want to make sure we give people less, not more. But lastly, we need patient samples. We need to build a biobank. We need to start looking at these studies. We want to look at, patients who are the only one in their family that have it, or the inverse, everybody else in the family has, but one person doesn't. The golden egg in this is if there's a twin study, one twin has it, one doesn't. That would be the best to do. But again, this needs patients, this needs physicians to work together, coordinate, communicate, and build up these networks to build up these sample databanks. So again, just kind of going back to what I believe this disease is from my experience with it, living with it for 10 years, is that the Dercum's disease is a trigger. It starts off the process, but at a certain point, the process becomes self-sustaining. So you have to treat it as a systems issue and not just one part of it at a time. We always want to focus on what's your most pressing issue at the time, what's bothering you today, and try to fix that. But oftentimes with this, you have to say, okay, this medication might not work for a month, it might not work for 2 months, but overall, addressing the system, you're going to start to see benefits. My personal theory as a scientist is we're hitting something in the mesenchymal stem cell population. We're hitting one of the pre-adipocytes. There's something there that's wrong, that's overproducing inflammatory markers, is preventing mature adipocyte differentiation. This is all theories, it's all speculation. I could be wrong. I'd be happy if I was wrong. It means there's more exciting stuff out there. But again, this is something where there's not research on it yet. And again, we need the patients, we need the physicians to work together, obtain samples, and get the cell lines going to start doing the research. So I have contact information on the screen. If you have any questions, feel free to reach out. Again, Dr. Herbst is the mind behind this plan. I have to give her all the credit for it. It's just been absolutely incredible working with her and the team. And if there's any questions, I'll take them. But also feel free to reach out to me by email, and I'll be around for the rest of the conference as well. So thank you.
Dr. D'Angelo, we do have some questions. The first question is the study that you referenced available to read?
So this is not a published study yet. This is more of just a case study of what has worked for me. The hope is that we do develop a study, and we can develop a team of physicians and write up a study protocol where we can study this in an unbiased setting. That would be the dream, especially if we can get the GLP-1s approved for this disease. So if you're interested in the study, reach out. We could use volunteers for that, but right now there's nothing published on this yet.
Okay. If Dercum's disease is an inflammatory condition, what markers would be present in sufferers to identify that it is indeed Dercum's disease?
So it's a really good question. The answer is we don't know. Just have to be completely honest there. With a lot of these diseases, we're seeing that the inflammatory markers can be normal, but we're having an improper inflammatory response. And that seems to be the case with a lot of adipose tissue diseases, is that when you look system-wide, everything seems to be okay. But there's aspects of adipose biology we don't understand that haven't been studied yet in the field, and there's a lot there to learn. So right now, there's no definitive answer I can give, unfortunately, but hopefully that changes in the future.
Another person's asking, do you have to be obese to have Dercum's disease?
So the typical presentation, to my understanding, again, I'm not a physician, but no. So it typically presents with obesity, is my understanding, but is not a requirement to have the disease. My understanding is that a lot of the obesity comes from the associated pain and lack of ability to move, chronic inflammation. Again, that whole process is a cycle. But I know from, again, talking with Dr. Herb, she has patients that are extremely thin and have Dercum's disease and still have Dercum's lipomas. So there seems to be some type of mutation, whether it's coding or non-coding, we don't know, but something affecting the adipocyte population within these patients.
What advice would you give to someone that is having a hard time with getting treatment and relief from their symptoms by working with their primary care physician?
Yeah, so this has been a struggle for me. I mean, it took me 10 years to get a proper treatment plan, but all of that was self-advocacy. Believe yourself, believe your symptoms, believe your experience, know your truth, and find something that works. Hopefully this can give some starting points for people with that, but the main point is, trust what you have, and really be prepared to advocate for yourself. This is a very misunderstood disease. A lot of fat disorders are, but hopefully the more study we put out there, the more we can learn.